Well, good morning, everyone. I'm Dr. Kim Williams, Chair of Medicine, and it is my distinct pleasure this morning to introduce our grand round speaker. Dr. Forrest Arnold is going to speak to us about the growth of the Division of Infectious Disease reviewed through cases. There'll be a very interesting approach to a grand rounds and how to grow a division relative to the needs of what you're seeing. Dr. Arnold comes to us. He's in his 24th year here at University of Louisville. He came from University of Tennessee where he did undergraduate work, did his DO school and internship at West Virginia University. First at the School of Osteopathic Medicine and then at the university. And he then went back to Tennessee for internal medicine residency, here for fellowship, which began a long tenure of fellowship and training and master's degrees and working his way up through the faculty from a lecturer to assistant associate professor and full professor. He's been our division chief since 2022. We kind of started at the same time. When you look at his CV, it's replete with clinical research, grant funding and accomplishments. If you add up the publications and podcasts and lectures, it's over 400. It's really having an impact where you are. Thank you so much for all you do and all of your leadership. And we're looking forward to learning a whole lot about infectious disease through cases. Thanks, Dr. Arnold.
Thank you. Appreciate it. So Dr. Callan gives grand rounds where he goes over cases, and I've always liked that. And none of mine have ever been like that. So now I get to choose how I do it. And this is how I'm going to do it. At the same time, I know that everybody is seeing a lot of new faces in the Division of Infectious Diseases. And so I wanted to introduce them. And I'm going to do it by going over some cases that we see. And I thought that would be an interesting way of meeting the division at the same time. So my conflicts of interest. All right, Jason. There we go. We have some sponsored studies, but honestly, when I'm at work, I'm thinking about being on my bicycle, which is a conflict of interest. And when I'm on my bicycle, I'm thinking about being back with my family. So we have a beautiful new daughter-in-law. My wife is thrilled to add her to the family. Now, when Dr. McClave gave grand rounds the other day, he gave his previous mentors. And then I went to research grand rounds where Dr. Klein said that was a good idea. I was listening. And so here are some of my mentors. The first is Jose Irazusta from Argentina. And he was my mentor in between first and second year of medical school and second and third year of medical school. And I did summer research. He was very exciting. He was a pediatric intensivist, and that wore off on me. And then Dr. Schauberg was the chair of medicine at Tennessee. And so he was an infectious diseases specialist as well and studied in Staphylococcus aureus. And if you see his picture, send it to me. And then many of you recognize Dr. Ramirez, also from Argentina. He was the chief here for the last 20 years and my boss. And so he had a great influence on a lot of the work that I'm doing here today. So I really appreciate all the work that they've put into me, and I just stand on their shoulders, really. So I told you what the objective is today, to go over these cases and tell you about the Division of Infectious Diseases. And so I'm going to go over some concepts of infectious diseases to make it clinically relevant for all of you who are here. So this is what we were left with at the end of COVID. And Dr. Burns was holding down the fort over at the VA. Sarah and I were at UofL seeing all the consults. She was helping with the bone and joint consults. The 550 clinic has over 2,500 patients, and we had those handful of people seeing them. Bill and Dina were our mainstay, seeing people every day. Dr. Voida stepped up her part-time work to help, and Bailey was our pharmacist in clinic, tying things together. And then we have our two stalwarts in the lab, Dr. Wolf and Dr. Maramuthu, who were there. And of course, during COVID, they converted their lab basically to a COVID testing lab. And so it was with this that we were functioning, but we were on a skeleton crew and in crisis mode. And it was non-sustainable, especially for me seeing every consult at university. So I began to add some people, and the first people available were my fellows. So that's what I did. Dr. Hannon and Dr. Aldas, I put Dr. Hannon, started training him with the ID fellowship, and Dr. Aldas as the medical director of the 550 clinic. And then Dr. Ali has a joint appointment as a PhD with the School of Public Health. So she works with us with our research, and Ryan Doster, physician scientist, doing his research, being a real feather in the cap of the division here. And then expanded out to transplant medicine with Dr. Thomas and Dr. Fayez, seeing not only bone marrow transplants, which we've done for years, but also solid organ transplants down at Jewish. So we even added a site. And now lately we've added Dr. Dash to be over the bone and joint system with another NP, Nicole. And Dr. Patel is our last faculty to join us just last month. And he is our contact to the Department of Medicine as the associate program director there. So the right side of the screen looks like it can hold more people. So we'll just keep going. And we've even started to branch out. We're now doing bone and joint consults at South, and we're seeing outpatient follow-ups from Jewish, Marian Elizabeth, and South. My goal is not to take over the city, but you know there is a need, and so we're trying to fill it. So let's go to case one. Here we have a 19-year-old female who had AML 3 years ago. She was treated, went into remission. Good, but then it recurred 3 months ago. She was treated again and went into remission, and so she came for a bone marrow transplant. So she got her conditioning chemo with busulfan and fludarabine, then her regular prophylactic antibiotics with trimsulfa, acyclovir, and fluconazole. On day 5 transplant, GCSF was started, and on day 7, she began having symptoms of a headache, vomiting, central facial paralysis, and mental status changes. And I put her Glasgow Coma Scale just to give you a sense of how significant her mental status changes were. So she was put on broad spectrum antibiotics, and she had a disseminated rash on her trunk and limbs. It was rounded erythematous violaceous macules infiltrated on palpation and some blisters with hemorrhagic content inside. And I think you can even easily see that from the back of the room. These are rather large. So she had pancytopenia, not severe neutropenia, but it was certainly present, and her blood cultures were negative, and she had some PCR tests that were negative for CMV, VZV, and HSV1 and 2. So what you're looking at here is a small blood vessel, and it's just chock full of neutrophils, lymphocytes, fibrin material, but then also, as the bottom of this description says, filamentous structures corresponding to septate hyphae. So that would be these guys right here. So my question to you is, what fungus is this? Is it a yeast? Is it a mold? Or is it a dimorphic fungus? Now, yeast can have what's called pseudohyphae. So that's when you have a daughter cell that buds off. And before the daughter cell buds off completely, she has a granddaughter cell. So in the family realm, we call that failure to launch, right? So then we have a great-granddaughter cell. So you get this string of yeast, and they kind of resemble a hyphae, but they're not really. So they're not really a hyphae, which means this is not a yeast. Now, a dimorphic fungus is a yeast at body temperature and a mold at room temperature. Okay, so this is a biopsy, which means they took it at room temperature. The patient was not dead. And that means that if this were a dimorphic fungus, you would be looking at a yeast, but we just concluded it's not a yeast. So it's a mold. Okay, so then you got to figure out which one it is. And there's some ways that I remember. I drew a septate acute angle branching mold here. Okay, and we've learned that, or maybe you didn't, but I can't remember, that acute angle branching goes along with aspergillus. And this is my little picture to remind you that acute angle branching, excuse me, goes along with aspergillus. Now, this is also septated, and I don't know what you're going to do, but a long time ago, before HIPAA and IRB, I had a patient named Septate, and she ended up having aspergillus. So it was just locked in for me. Now I've got aspergillus and septate for the rest of my life. So you can see your own patient, I guess. And let me show you another picture so we can help determine whether or not this is septated or acute angle branching. This says septate hyphae and intravascular conidiophores are evident. What's a conidiophore? I had the same question. I have to remind myself. That's these guys up here on the mold. Okay, so you're looking at strands of this right here. And honestly, I can't tell too well if it's septate. Maybe there's one. Or the branching, so we need another picture, and here's a GMS stain. Now this picture shows it a bit better. And here you see much better that there are some septate, and this is a pretty good example of 90-degree branching. Okay, I just told you that aspergillus is septate, but acute angle branching. So this is not aspergillus. So what is 90-degree branching? It's mucor, but mucor doesn't have septate. So it's neither aspergillus or mucor, and those are the two molds that all residents learn. So when we get new fellows, we have to teach them the other one. And you've learned the other one. So that's what we're going to go over pretty soon here. Fusarium oxysporum. So this is 90-degree branching with septate. And it makes lesions like this. Here they are a little more mature. This lady went on to have positive blood cultures, and she was treated with lipoampho-B and voriconazole, but it progressed to her brain, and she herniated and didn't end well. Anyway, the risk factors for that are severe neutropenia. She had neutropenia, remember, it wasn't severe. Recent induction chemotherapy for a bone marrow transplant, yes. And then graft versus host disease is the other one. So these may be pictures that you recognize from the textbook. And they're pretty because these have been taken out of the biopsy and cultured on a plate of its own. And so this is what they call canoe-shaped macroconidia, okay? And so they do look like, they do look like canoes. And so if you come over here to the actual biopsy, you can kind of talk yourself into some of these looking like canoes, so that the patient actually kind of looks like the textbook of these pretty canoes over here on the left. Okay, so this highlights a case that we are seeing in our transplant. Dr. Thomas and Fayez have both have done an extra year of fellowship to learn about bone marrow transplants and infections in solid organ transplants. So when you see them, you're seeing another area of infectious diseases, and these are a couple of the new faces. Let's go to case 2. 20-year-old healthy male student at a local college. The septic shock in the ICU is fine 24 hours ago. And when you look at this rash, you pretty much know what the diagnosis is. So let me go one step further. The question is, which serogroup of Neisseria meningitidis does he have? A, B, C, Y, or W135? Well, I can tell you right now, it's a little bit of a trick question because there's no commercial tests for the serogroups. So if you really want to know serogroups, you might want to know what's in the community. And the only way to do that is to do a study, swab a bunch of people, maybe these college students, and then figure out which serogroups are in your community. So that's what we did. The risk factors for Neisseria meningitidis are medical, complement deficiency, asplenia, HIV, and cochlear implant. Then there's social ones. So if you travel to an area, there's several in Africa that have epidemics of meningitis. If you're a microbiologist working with this organism, so if this patient were to show up, you get a culture, you'd want to call microbiology and give them a heads up. Say, hey, this is Neisseria, just so you know, you might want to work it up under the hood, and they will. Then if you're going to college or the military, that's an increased risk factor. Now the CDC doesn't put up here, and what you might think of is if you don't have a vaccine for it, then you would be at increased risk for it. And that it makes common sense. Maybe it hasn't been shown, and so that's why it's not up here. But there are 2 vaccines, remember. One is for ACYW135, and that's for all new military recruits and college students. So pretty much everybody gets that one. Then there's another one for B, and that's indicated for immunosuppressed patients, and it's optional. So I opted in for my children going to college. Now the ACYW135 put them on the couch for half a day. So when I told them it was time to get the B, they were not happy about it. So I said, well, you'll be walking down the hall, stepping over bodies that are dead and saying, I alone got the meningitis B vaccine. But that didn't have the desired effect I was hoping in my child. But he was compliant and got it anyway. So they're all vaccinated up and ready for an outbreak. So here is meningitis through the years. And I'm going to make a case that there's one of two answers to my original question about serogroups. So meningitis has decreased over the years, and it's probably because of the vaccines. And if you notice, the meningitis ACYW135 was released in 2005, and then the B in 2015. Now, what's odd is that meningitis B, for which there was not a vaccine until 2015, also went down when this other vaccine came out. Isn't that interesting? And then they came out with the B vaccine. So it kept trending down until Y in 2001, went up in 2002, and even further in 2003. So that this year in February, the CDC put out an alert to say, hey, meningitis Y is an outbreak, probably encouraging people when they go to college or military to get that ACYW135 vaccine. So one of my answers for our question, which serogroup, it may be that our college student had serogroup Y because there's been an increased outbreak. But really the only way to know is to do the study. Now, this area is an area I want you to focus on, 2014 to 2017. And so when we look at the age groups of who had meningitis in that time period, we see that B is a real flare in the 16 to 18 age group. And that's just the group that's going to college or military. And so that's my other answer for which serogroup is this. He could have Y because there's a current outbreak, or B because kids get a lot of B when they go to college or the military. So here is our study. We wanted to answer what is the carriage rate and what are the serogroups. And our hypothesis was that the carriage rate would be less over time because of the graphs I just showed you and because of the vaccines. And the serogroups, we really had no idea. So we had to look at that as well. You had to be 18 to be in the study. That was convenient because to get consent of a 17-year-old, you're really getting assent, which is complicated. We didn't want to go there. You had to be willing to get swabbed in the back of your throat. You had to live on campus and come to UofL and be swabbed and enrolled within 48 hours. So if you were a summer student and stayed over, you were ineligible. We wanted you coming from wherever you were in the United States to UofL, so that's your baseline, swab you on the first day, and then a month later, and then 2 months after that. So we can see. We're expecting it to go up, but we don't know because, students come together and they mingle and all that stuff. So you also needed to live on campus affiliated housing. So this is a map of the campus, Belknap, 3 miles away if you're not familiar. I tried to orient you by putting I-65 on here. And here's the Watchtower, which is the highest building on campus aside from this tower. So the purple buildings are the ones where there are dormitories. And so there's several in the center of campus, and all this affiliated housing is on the periphery. So there were a lot of people that could be candidates for our study. Now, we didn't have long, because remember, you had to come and get swabbed within 48 hours of coming to campus. School starts at a certain time, so people, all come at the same time. They're a little staggered because of band and different activities like that. So our first time, we had just over 1,000 students enroll in this study, which means we enrolled 1,000 students in 2 weeks. That was a feat in itself. 926 of them came back a month later, and then 2 months after that, 825 came back. So the first student was enrolled August 3rd, the last November 22nd. So we slipped it in right before the Thanksgiving break, and we completed the whole thing in 1 semester. So we got 40% males, 60% females. 3/4 of them were first-year college students, 17% were second year, and then the remaining 9% were third year and above. So you could be even a master's student and come and get swabbed for this study. So what we found was 3.5% of everybody healthy coming to us and getting swabbed had Neisseria meningitidis on the back of their throat. Whoa. And then we swabbed them again in a month later, and it was 3.9%. And then 2 months after that, it was 5.7%. So that's a 2.2% increase, or a relative 63% increase in colonization. Now, some studies will only give you the relative increase, 63%. It looks huge, but they need to give you both numbers, the absolute and the relative increase. So this is a listing of the serogroups, who had which serotype. So a great chunk of them had meningitis B, kind of like that one figure I showed you with the age groups. Then a couple had meningitis Z and E, which are rare meningitis serogroups for which there's no vaccine, but they do exist. And then this capsule null is also a good chunk of the serotypes, but it's non-pathogenic, fortunately. So meningitis B responsible for 39% of all the carriage. The astounding thing was that nobody had AC, Y, or W135 as a serogroup. That was an impressive thing. So that tells us that the vaccine is working, and keep getting it. Not the vaccine is working, okay, now we don't have to get it. All right, we certainly, the recommendation is out there to get the ACY W135 vaccine. So I showed you this before about the medical and social risk factors, but we asked them at each visit a survey of what are you doing? And these were the significant things that they showed. Now, it was positive for smoking tobacco, vaping, and smoking marijuana, which I assume is because they're sharing cigarettes and whatever else they're smoking with. Second-year students, perhaps because they have more relationships already established when they get to campus, I don't know. And then partying and kissing is kind of obvious. So this is the team that helped us accomplish this two weeks, 1,000 students. And this is the team that we trained them in an internship to learn how to, all the aspects A to Z of research, and they can go on and be research coordinators. And so they will butt off to residency or butt off to be your research coordinator. And so this is open to anybody doing research in the university, but I have a preference for the Department of Medicine. I'm biased because I am Department of Medicine, and I want to give to us first. You just have to ask first. We also need to hear about that well ahead of time, because this internship is 6 months. And so we need time to bring them here and train them and get them ready to go. And so the earlier I hear from you out there, then hopefully I can hook you up with one of our people. And that's how that works. Let's go to case 3. This is a 72-year-old man with a history of a living donor renal transplant 9 months ago, who presented with acute onset shortness of breath, accompanied by an intermittent mild dry cough. He had a fever to 101. He was hypoxic. He didn't usually wear oxygen at home. He was on 4 liters and a little tachycardic. So he did what he's supposed to and took his trimsulfa prophylaxis for PCP and his valganciclovir for CMV prophylaxis. So that lasted 6 months from the renal transplant, but his symptoms started at 9 months. So on physical exam, he had a fast respiratory rate, the fine crackles, and the graft site was non-tender. So what's to the left here is in months, and now we're going to go in days for the hospital days. So on hospital day 1, he has a chest x-ray. This chest x-ray is actually, with the degree of shortness of breath he had, kind of unimpressive. There's maybe a little bit of calcium in his aortic knob, but that doesn't explain his shortness of breath. There's diffuse, maybe some haziness, and PCP can look like anything. That's certainly in the differential, but this doesn't show us a lobar infiltrate like I would expect with Legionella or Streptococcus pneumoniae. CT scan was a little more revealing. It showed some ground glass opacities in the upper part and scattered throughout. Honestly, this looks a little bit like the beginning of COVID. And so this is what we learned in that pandemic that COVID looks like. So there are different organisms associated with different time periods. And I could ask you a multiple choice question that has, okay, what do you think this is? In the first month, you might have a wound infection, HSV or Candida. And then after that 1 month to 6 months, we could add some esoteric organisms like nocardia, mycobacterium, CBV, EBV, and then aspergillus or cryptococcus or an endemic fungus like histo here or cocci in the Southwest. But this guy's at 9 months. And after 6 months, there's really no predominant organism, but everything is possible. And so the multiple choice question I'd make for you would be like A through M, you know, the possibilities. It'd be too long. So we checked a bunch of tests, and several of them, these are all negative: Legionella, histo, galactomannan assay for aspergillus, crypto, and this respiratory viral panels, completely negative, including COVID. So we also checked for sputum AFB was negative, PCR for PCP for PCR for PCP is negative. The CMV results, over 400,000 in the blood. At this time, ganciclovir was started for a week, and in just a week, that PCR for CMV went down to 136,000. So there was a clinical response as well with a decreased shortness of breath. So this guy has delayed onset CMV pneumonitis in a high-risk solid organ transplant patient. And I'll go over what's high risk in just a second. So this was also a case report in CID, not our person, but it matched this person with, this was actually a review, and it showed a delayed onset primary CMV disease. And CMV we think of with lungs, and we see it in BALs a lot, but it's much more famous than it is, it's very rare. So it gets, and this person was severely immunocompromised, and so that's the type of person that gets it, and even then it's rare. So the risk factors are different for hematopoietic stem cell transplant and solid organ transplant. Our guy had the high risk, the donor was positive, the recipient was negative. He had no antibodies, and he was introduced with CMV. So in bone marrow transplants, it's the opposite. The donor is negative, the recipient is positive, and then the induction chemotherapy takes away your antibodies. So they're at high risk there as well. So CMV can be manifested in several different ways. You have CMV infection on the left, CMV-mediated immune modulation on the right, and then CMV disease can be manifested as CMV-related viral syndrome or tissue-invasive CMV disease. So the diagnosis of CMV pneumonitis, all of them encompass clinical signs and symptoms. So if you get a bronch for some other reason, they don't have symptoms, then they don't have CMV. So there's proven, which shows that the CMV is in the path sample or in the micro sample, okay? Then the probable shows that the CMV was in the BAL fluid with these signs and symptoms in an immunosuppressed patient, or possible is CMV in the blood like our patient. So our diagnosis was supported by the improvement in the signs and symptoms on ganciclovir. So the study above was this review of 176 patients, and 51 of them went on to develop CMV disease. They got prophylaxis for 3 months with ganciclovir or valganciclovir. Remember, ganciclovir is IV, valganciclovir is PO, and when you take it, it turns into ganciclovir. So all the infections came after 3 months, and they had different types of infections. They had primarily CMV syndrome, tissue invasive disease, and a GI infection. And only one person of that GI infection actually had pneumonitis. So this is 176 immunosuppressed patients, 51 had infection, and only one had the pneumonitis like our patient. It is a very rare infection indeed. So the standard of care now is to give prophylaxis for not 3, but 6 months. And so that's at least 6 months, frankly. So, and that's why. Let's go to case 4. 24-year-old healthy female from the Caribbean island, fever of 102, chills, malaise, and arthralgias, waxing and waning for 2 weeks. Also night sweats, dry cough, sore throat. Now this all went away, which was great, but it came back 4 days later. She had a red rash on her left upper extremity, which resolved 4 days prior to admission. She had normal childhood vaccines. She had had vaccines for COVID or flu, but they checked it in the ER and it was negative, as was a strep throat test. Basic labs were normal. They didn't check inflammatory markers, and a chest x-ray, the radiologist said, had a possible infiltrate in the right lower lung base. So you can talk yourself into a right lower lung base, and this is a healthy 20-some-year-old, so perhaps that is an abnormality there on the chest x-ray. So her other history is pretty benign, and she only took acetaminophen as needed. So her social history showed that she immigrated from Cuba as a child. She works in retail. She recently visited Cuba for a week-long family event. The symptoms began on the day of the return to the United States. So she lives in a roommate in an apartment in Louisville. She's sexually active with one male partner, and he uses a condom, she thinks. She has one cat in her apartment. She denies smoking, vaping, but uses occasional alcohol. So from an infectious diseases standpoint, at this point, we're thinking, oh, is Bartonella in our differential? Cat scratch disease? Maybe she has acute HIV. That can happen. People go away to another country. It's like going to Las Vegas. Don't ask, don't tell. And then they come back with HIV. And when you get HIV, it's actually cold symptoms. People chalk it up a lot to just a viral illness. It is a viral illness, but it's HIV, not, influenza or something. Her fever was 101.6, and the rest of the vital signs were stable. In fact, her entire physical exam was pretty normal up there. She had a little bit of remains of that rash on her left upper extremity, and even this was not that impressive. So my question to you is, what do you think? And this is not any of those things I talked about before, but it's fever in a returning traveler. So you get a healthy person, went somewhere, comes back, has a fever. And these are the things you think of the most: dengue, malaria, Zika, and chikungunya. And they're at the top of your list. Right now, this is a trick question because the answer is not up there, okay? So I can't ask you. What you need is another possibility, and it's this one, Oropouche virus. Oropouche virus. That's one I haven't heard of. So I got to put it in your brain somewhere. I got to find that landmark. It's a bunya virus. So you can categorize it with your bunya viruses. I'm sure you have a whole collection of those: Rift Valley fever, Lacrosse virus, Hantan Lassa virus, Sin Nombre virus, and now Oropouche virus, okay? So it's just a virus with 3 RNA parts and surrounding proteins, like a lot of viruses. So it came from South America, and it wasn't even in Central America so much, except that it went there in animals first, and now there's some cases in Central America, and now it is in the United States. So it didn't come to the United States until May of this year, and you see there was a rapid increase that peaked in the summer. So it's never been in the US, and now it is. And then it's down. I don't have September, October numbers for you. So the first case in Cuba was in June, but it was probably before that. They just don't have as good of resources to do the surveillance. And I'm sure it was in Cuba before it got to here. At the same time, people go from South America. They don't stop in Cuba on their way. So maybe it really was in the United States first. So here is where it is in the United States. Of course, it's in Florida, but there's only 4 other states. And one reason I go over this is because one of those 4 states is Kentucky. So, the summer infections are kind of over and the travel, but the mosquitoes are still down there and people are still traveling down there. So when we see fever in a returning traveler, we're thinking dengue, Zika, chikungunya. We also need to add Oropouche to our differential now. And this is why it's been here. Of course, all these were brought in from travelers, but this is where they're coming. And remember, Louisville has a large Cuban population, and we have a large refugee population. So people are coming from different areas of the world to here, and sometimes they have infections from those other regions. In Cuba alone, they had over 500 cases, which is way more than compared to our, say, about 74 cases or so in the United States. So it's just level 1 in practice, usual cautions in the US. That's as low as you can go. Level 2 in Cuba, and practice enhanced precautions means wear bug repellent, don't go out in the evening and wear long sleeves if you do, so you don't get bit. Okay, I need to tell you about this so you can recognize it. The incubation period is 3 to 10 days, and the typical symptoms are what our patient had: the fever, malaise, and the headaches, maybe chills, arthralgia. And so I underlined those major symptoms. Some patients go on to develop some very unusual symptoms like photophobia, retroorbital eye pain, dizziness, nausea, vomiting, or even a rash. The rash tends to go from the trunk and spreads outward. Is that centrifugal or centripetal? Centrifugal. Okay, a centrifugal rash. Less common symptoms can include conjunctival injection, diarrhea, severe abdominal pain, and then the hemorrhagic symptoms that can go along with that. So rarely you'll get somebody that gets meningitis or something serious like encephalitis, less than 1 in 20. 60% of the people will have be symptomatic, which tells me 40% will not be symptomatic. See, that's a huge range between asymptomatic and encephalitis or meningitis. And we see the same thing with COVID, right? Some people are asymptomatic, some people are on the ventilator. So the symptoms just last 2 to 7 days. And then about 70% of people get it, have the symptoms, they go away, and then they recur, which is exactly what happened in our patient. So the definition from the health department says you have to have at least fever, headache, and myalgia, like fever, headache, plus one of the others. Myalgia is one of those. That's a really vague symptom. So it's kind of a low bar to fill this first criteria. That's why there's a couple more. And so you need to test negative for other possible causes like dengue and have an absence of a more likely clinical explanation. And I would add to that, you need to have been to a country where it is. And so, because it's not transmitted human to human, it's transmitted mosquito to human. And we don't have those mosquitoes here. So it's diagnosed by this test. It's just a blood test, and we have to send it to Frankfurt, and Frankfurt sends it to the CDC, so their answer doesn't come back. So in the meantime, we should be doing also the tests for dengue and Zika and chikungunya. So you don't want to wait on the state to do their test before you do the rest of the workup in the patient. So the treatment is just symptomatic. You give the people fluids and give them medicine. You just want to avoid aspirin and NSAIDs and use acetaminophen for that. There's no specific treatment for it. And then the health department says if they have bleeding, hemorrhage, confusion, decreased level of consciousness, send them to the hospital. You pretty much do that for any illness at any time. So I found this table, which is kind of helpful because it compared Zika, dengue, and chikungunya, which is the closest related to our Oropouche virus. And you'll see that they're all transmitted by Aedes aegypti mosquito, and so is the Oropouche virus, and this is the mosquito. So we're all familiar with that. But if you notice, the Oropouche can also be transmitted by this Colocoides periensis, and that the layman's term for that is a midget because it looks like this. Now it's hard enough to see a mosquito on yourself, but that midget thing, that's why you want to use the bug repellent and the long sleeves and just don't go out when they're out. Because they're so small, you probably got it by the time you see them. So I filled in the table for the others, and what's impressive about this table is it's very similar for all four of the viruses. They're all in the same part of the world, Caribbean, South America. The incubation is 2 to 3 days to 10 to 12 to 14 days. The presentation has similar, fever, headache, conjunctiva. And the laboratory, although the thrombocytopenia is the same in all of them, that's the thing that stands out. The PCR test or the ELISA test that differentiates them is specific for that virus. The treatment is supportive in all of them. And then they all have some degree of pregnancy risk. The worst, of course, is Zika virus that we heard about the other year. So our global health and travel clinic, the surgeon clinic, we managed to keep open throughout COVID and beyond with just our skeleton crew. And now we've got it built back up and we're open for business. We've been seeing people. So if you're going to an exotic country, come see us, or if you need a green card or US citizenship, we also take care of that. So the cases today that I've gone over have been Fusarium, the forgotten relevant mold. So we need to look at that. Then Neisseria meningitidis, certainly there's a carrier state there, but the CDC has issued that alert for serogroup Y, and then we know that B is also increased. And so we want to be sure to have an eye out for that. CMV is a famous virus in transplants, but remember it's rare. And so there's certain degrees and methods to make its diagnosis. And then Oropouche is a novel virus in the US and even in now Kentucky. So these are very relevant things to this area. And so I couldn't do any of this without our team, which has expanded greatly. So in charge of the fellowship, we have Dr. Hannon and Dr. Thomas. And then in charge of our helping with our research is Dr. Ali. I told you about our bone marrow and solid organ transplant infection faculty. The HIV clinic, we've added some NP and with Matt there joining Bill and Dina. Dr. Voigt is still there, as is Bailey, and now Dr. Aldas. Then in the lab, we have a biobank. So if you're doing research that requires a biobank, remember us. We have room in our freezers, multiple of them, and Dr. Maramuthu manages those. In fact, you're going to hear from Dr. Wolf at Research Grand Rounds today. Our bone and joint infections, we have Dr. Dash helping and overseeing Sarah and Nicole. And so the three of them are seeing an immense amount of activity at different sites. Dr. Burns is still at the VA holding steady, and we have Dr. Patel, who's our foot into the internal medicine door, and of course Dr. Doster in this building doing his research. So I can't thank enough, even our gratis faculty down here. I guess as people retire, it gets bigger. Anyway, that is our presentation today, and thank you, and I'll take any questions at this time.
That's good. Want to tell us more about the program? I know you've told me about it before, but where are your candidates for the clinical research training positions? Where are they really coming from? Well, it seems like they're coming from all over.
Yes, they are coming from all over the world. So these are foreign medical graduates, and they probably applied to residency or want to apply to residency. And so before they do so, they know that if they're a foreign medical graduate, they kind of have to have something special. So coming and doing this research beefs up their CV. So we're helping them do that, and they're helping us with our research. And so they are actually beefing up their CV because they're learning this research. They're learning about the FDA. They're learning about the aspects of research, how to enroll people, and with some oversight. And then they could do it independently, as we've done with some people in the Department of Medicine, and I'd just like to keep doing that. So that is a 6-month, and they get a certificate. And so then if they want to stay on, they can, and a lot of times some of them do. We've had some that go away after a year, some that stay with us for 2 or 3 or 4 years.
So, do we have outcomes already? Or how many of them are getting residencies, or how many do we end up hiring as a researcher?
We do, but I can't just tell you off the top of my head. I can tell you that we have about 30 to 35 at one time, and we match about 10 to 12 of them. And so the others remain and keep doing the research.
Any other questions? You blew everybody away.
Yeah. Oh, yeah, maybe Jason knows some online. Okay. All right. Well, thank you for coming and being aware of the Division of Infectious Diseases. Yes.
For when you test and you find something like Oropouche, what's the you have a patient and then they've already resolved and everything and they're healthy. So what's the point of doing the test and finding Oropouche in the first place? Is there a reason that you all would?
Okay, so the question is, yeah, the question is, what is the relevance of diagnosing Oropouche? And when you see a patient, they are abnormal, which means they have something wrong with them. And to get a diagnosis and be able to say, this is your diagnosis, it offers a lot of relief. And it also tells the health department, and that's how they found out about the one actually in Jefferson County, that we have it here. And so we need to look for that. Who would ever think of Oropouche, last year? And so now we know when all these other tests like Zika and chikungunya and dengue are negative, they actually do have something, and we need to know. Remember Zika, the benefit of diagnosing that was that it was so associated with the pregnancy abnormalities. And so it made some people hesitate because they had a trip coming up to go to a place, where that mosquito was, and they may have, at least they had to be fully informed. Like you are pregnant or you're about to be pregnant, right? And you need to know about this virus because it's out there. So is there somebody else? Okay. Thank you for coming.
Really good.